Welcome back, everybody. It's great to be back again. I'm here today with Dr. Dayspring. He's a world-renowned lipidologist. So I'm going to read his introductory first, and we'll kind of grab into it. So Dr. Dayspring is an internist who's a fellow of the American College of Physicians, who also serves as a social media ambassador to the European Atherosclerosis Society and National Lipid Society. He's practiced internal medicine, lipidology, women's cardiovascular health for 37 years in New Jersey, and then worked 7 years as a scientific officer for 2 large cardiovascular biomarker labs in Richmond, Virginia. For the last 5 years, he's been a lipid specialist advisor for Early Medical, which is Dr. Peter Attia's practice. Great to have you here today to talk to us about.
Yeah, it's fun to be chatting with a colleague in Richmond here.
I know, yeah. So it was interesting talking with you before and also watching some of your previous podcasts and things like that. So first I want to talk about, how do you go, because when I was in medical school at MCV here in Richmond, lipidology, I didn't even know there were lipidologists, right. So I didn't really hear that term until I started doing my integrative functional training back in 2012. And even practicing locally, I had never didn't know people actually did this, and then come find out you've been doing it for decades. So kind of walk us through, how do you go from internal medicine, what your progress was to get to be literally a world-renowned lipidologist?
It's been quite a journey for me, and I had no grand design to wind up where the heck I am. I joke, I went to medical school in the dark ages, 1968 to 1972. And never mind the science of lipidology, we barely knew what lipids were. The only lipid being measured in patients at that time was total cholesterol and also triglycerides, which were not understood at all. Yeah. And there were virtually zero lipid therapies. So, we were told at what level of cholesterol to worry about, but there was nothing to do about it, even if somebody had FH. And back in those days, the worrisome level was if they're above 300, you got a problem. And if they're not, don't worry about them. But somehow I got very interested in cardiology because at that time, when you were a young stud resident and doing night call and moonlighting in ERs during your residency, the biggest crisis was acute coronary syndromes. They were rampant. They were coming in every night. And what did we do for them? We didn't have to CPR them in the emergency room. We put them at bed rest, gave them oxygen, maybe heparin, treated ventricular premature contractions totally unnecessarily. So that's where I started. It's like before the Wright brothers invented their first airplane, and now we're watching rockets fly around. So I went into the private practice of internal medicine, still very interested in cardiology because it was the primary pathology that was killing people. By that time, we had cured bleeding ulcers with Tagamet, so that wasn't a problem anymore. So early in my career was get on the hypertension bandwagon. That can do good to cardiovascular disease. Still no lipid management, and what the rudimentary lipids we were measuring, you didn't know what to do with them anyway. But sooner or later, it was in the mid-1980s that some information started to come in that, you can measure lipids, and if you can reduce cholesterol in the blood, however you're mentioning it, and by that time in the 80s, we had the calculated LDL cholesterol. Yeah. We had direct HDLC measurements, so we were a little smarter. Had triglycerides, still didn't know what to do with them. But at least we knew, hey, then the first drug that worked was bile acid sequestrants, cholestyramine. Pretty much an unusable drug, but it did lower LDL cholesterol a bit and did reduce outcomes in a big clinical trial. Then the first fibrate trial came in, gemfibrozole, first primary prevention trial really done with the Helsinki heart trial, where gemfib, as a monotherapy, reduced events. That was published in 1987, and what hit the market in 1987? Statins. Mevacor, lovastatin being the first. Guys like me who started to delve into studying lipids in the 1980s, of course, became major statin users. Probably most of the internists and clinicians at the time used statins very cautiously, if at all, because although they lowered cholesterol, there were no long-term safety trials or even outcome trials. We were believing, hey, the cholestyramine lowered cholesterol, it works, statins lowered cholesterol more. And of course, 1994, 7 years after they hit the market, the 4S trial with simvastatin, outcomes beneficial. very soon, within the year, a primary prevention trial west of Scotland with Pravachol worked. So statins came along. So I was, boom, boom, really being aggressive with lipid management by that time. Now, back then, when you somehow discovered yourself, and it was all self-study in lipids at that time. There's certainly no society of lipids.
Yeah.
You just try and delved into the literature and learned what you could. But interesting, pharma understood, here's a doctor up here, he's writing a lot of statins. What does he know that doctors who aren't writing a lot of statins? So they sort of hang around with you and they interview you and listen to you, and they get the feeling that you might know what you're doing, so they give you an opportunity to, we would like you to speak to other doctors. Okay, so what they do is they send you out into your local community to basically speak to a few friends or colleagues who know of you who might come to a lecture you're doing. And by luck, my self-study up to that time, I sort of knew a little bit what I was talking about. And the doctors I talked to, better yet, they sort of liked the way I explained how I approach lipids, what I know about lipids. And it spreads like wildfire. If you get the reputation that you're a good lecturer, and it's really the pharma people who are monitoring you early on at that time, back in the late 80s, early 90s, you start getting invitations to lecture here, there, and everywhere. So I love doing it. I started to accept invitations, and now you're traveling out of your local community, even out of state. And when you start doing that, and sooner or later you're lecturing at medical schools or to faculty, doing a grand rounds at a hospital, you start to meet the higher ups in lipidology, and you get to interface with them a little bit. They get to know who you are. And you start also, when you're at that, you start attending more national meetings. Now, there was no lipid meetings to attend, but American Heart, places like that, endocrine societies, and you'd meet more and more of those high-level colleagues. And before I know it, I was, and I grabbed the high-level colleagues, and I annoyed the heck out of them, but they sort of liked the way I do. By that time, I had a reputation as being a great illustrator of lipoproteins and lipids in visual, mostly PowerPoint or so. So they all wanted to know how I did that. Long story short, I got to meet virtually everybody who's anybody in lipids, became friendly with them. And then you start getting invitations to speak at national meetings. Hey, write, publish a chapter here, help me co-author this paper here. And here I am. And even when you get to a point where you're so busy doing the educational things, I had to bring in a colleague to assume much of my practice, keeping only the tough cases or some new cases. And then at a point, Father Time gets you. And I really can't keep doing this forever, practicing myself. And I have so many opportunities to lecture, write, and teach. And then I got the laboratories who wanted me to come down as a scientific officer. And it was a wonderful opportunity that I just fell into, and they recruited me because this guy can understand lipids, he explained lipids, and he speaks to clinicians. The laboratorians are not always the greatest people to speak to clinical guys like yourself. They just don't sort of speak the same language. But so I got for 7 years to hang around with world-class clinical laboratorians, became friendly with many of them, started attending their meetings. And it helped me better understand their part of the lipidology equation, translate it to real-world guys. And so I just became even better at understanding lipid speaking. The National Lipid Society started just before 2000. By 2004, they decided we want to start a journal, and we want to start fellowships for lipid guys, and ultimately we want to create a lipid certifying examination. So the American Board of Clinical Lipidology was formed. I was a little bit in on the ground floor on that. I helped develop a lot of the self-assessment programs. I would teach at their Masters of Lipidology course. Before you know it, so now they're going to start certifying lipidologists. So they brought a group, just under 100 of us together. I believe it was in Chicago. And they put together the first beta trial exam. And, so they brought in quotes, best and the brightest. We'll give you guys the exam and see how you do on it. Do you like it? Was it fair? Are you guys all going to fail this or pass? So, one feature of that was, hey, if you took the exam, they would grant you certification in clinical lipidology. Now, again, they were recruiting people who were likely going to pass the test no matter. But we took the test. I get in on the ground floor. I have certificate now 28 as far as, I don't know what to up there now, but in the thousands or so.
Okay, great.
Just continued to teach. And but now I was into the lab. And the great thing about the lab, I'm called their scientific officer because I know a lot about this stuff. But these labs are very busy doing hundreds of thousands of assays, and you get doctors calling up. I don't understand this. What can I do? So, hey, Dayspring will get that phone call to try and make it.
And which labs were those that you were doing that?
I started with Health Diagnostic Lab, which was an incredible lab. And again, world-class laboratorians. Ultimately, laboratories get into trouble with third-party payers because they're always going to be accused of unnecessary testing. And third-party payers don't like to pay for it. One of those third-party payers is the government through Medicare and Medicaid. And they surely, when they see a lab is really creating a lot of bills, they come down with their investigators. And, hey, unnecessary testing. Every test was ordered by a doctor practicing medicine. It's not what the laboratorians say.
Yeah.
But they'll say, hey, do you really need this many of those tests? So ultimately, they stop paying them and the labs fold. So HDL ultimately went into bankruptcy after a decade, but they were bought at the bankruptcy sale by Truth Health Diagnostics, who came in. They kept me. They wanted me to continue as the scientific officer. They kept a lot of the people. They narrowed down the group. But ultimately ran into the same trouble. After 4 or 5 years, they're being investigated for unnecessary testing. The screws are put on them, and they have to fade away too. That was 2019. I joined HCL in 2012. And then my friend Peter Attia said, Tom, I know the labs are not there. What are you doing? I said, well, I guess I'm retired finally. And I was into my, late 60s at that time, early 70s. And Peter says, well, I have this very specialized practice, and I've leaned on you for the last decade. I knew Peter for a long time, and we interacted on lipids a lot, me trying to teach him and help him solve. So he gave me an opportunity to be a lipid specialist in his practice. Now, I don't practice there, but I look at lipids. He's got internists working for him who do the practicing and prescribing them himself. But I will talk to them. If they get a lipid thing, we'll talk in a group. Here's what I think is going on. Here are possible solutions to it. Peter, as you know, does a lot of education with his podcasts, writing weekly emails. So I get involved in any of them that are lipid. If you go through his podcast library, you'll notice a dozen of the world's top lipid thought leaders. I've done 8 of them with Peter, but there are many, many more. But I recruited most of those speakers to come and speak to, because I know all the top guys.
But it's kind of
I am, and the last thing I'll tell you is at a certain point, when I was started to slow down a little before I left the labs, I got involved with social media. Twitter was invented and it was there. Ultimately, LinkedIn. So I started going on Twitter and started publishing, writing little tweets, and put all my teaching slides, which people love. So before I know it, I got like 37,000 followers on Twitter. Not bad for somebody who just tweets lipids all the time. LinkedIn, I only accept if you're a professional. There's a lot of laymen and who knows who following me on Twitter. But now all of a sudden, you're recognized far more globally than you were. I've done a number of talks around the world, but I still didn't have a high-level recognition. But once I hit social media, you mentioned I'm a social media ambassador for the European Atherosclerosis
I've never heard that before, Michael.
Yeah, because they contacted me, and we love the way you're educating on social media, and we'd like you to copy us on some of the tweets or help us with some of our endeavors. So why wouldn't I? And now all of a sudden way more connected globally with the top thought leaders in the world than I was mostly connected in the United States, and now it's globally. So it's been wonderful.
That's a great summary. I haven't actually heard all those different things put together with your story, so it's really great to hear that. It's kind of interesting, the whole lab thing, because I, as a practicing clinician, have the exact same issue where it's like, this lab is paid for by this insurance, this lab is not paid for by
Very
this insurance,
difficult.
this one is a cash base, and so I have to create my own ecosystem where it's like, I want to do, Cleveland Heart Labs, which has the NMRs and all the advanced stuff we'll talk about here in a little bit, and you realize, hey, that's going a different pathway. If you use, certain labs like doctor's data don't accept insurance. If it's a certain carrier, I'll use it for that, and so I almost have to become like an insurance expert. And I've actually gotten some letters from certain carriers, which I won't mention here just in case their representatives are listening, who have sent me cease and desist letters that if I keep on ordering this lab, they might drop me from their insurance. And so in the way my practice is set up right now, I do like a membership and insurance that allows me to use insurance for labs that are appropriate. It also allows me to use the patient's resources for labs that are outside their scope. But you got to stay on your toes, because if not,
terrible. I don't know how anybody practices the type of medicine you do, or even run-of-the-mill internal medicine or family practice, because everybody's trying to put handcuffs on you. With no recognition that you're a well-trained physician, you have your own CV that shows you're not some dummy who's discovered testing here and there, and you're doing it appropriately, but they don't want to pay for it. They want to maybe pay for a lipid profile, a glucose level, even fight some people on A1Cs. And good God.
I first ran into that when I was in the military. And that was this was 2004, before Medicare was paying for screening colonoscopies. And so the United States military followed the same standards as Medicare. And it's just common knowledge, if you're in the military, just being in the military increases your risk for Parkinson's, ALS, the chemicals you're exposed to, first Gulf, second Gulf, you're Vietnam. We know these veterans are getting bladder cancers, all these things. So like all my guys that came in to see me, it's like everybody gets a colonoscopy.
Sure.
Insurance wasn't paying for it. So I have this colonel or general, a sergeant, do you have blood in your stool? And they'd say, no. It's okay. Have you ever in your life ever had blood? When I was 12, bingo, and I get the insurance to pay for it. And all of a sudden, it's this game where, like, I know you're high risk because of your history. I know it's becoming more common. I have to massage the system. And then 5 years later, it's now considered okay for screening. And now, as of like a year or two ago, now it's okay to screen a 45-year-old to 40 for colon cancer.
Yeah, they're catching up what you knew 20 years ago,
Well, that's that's a great transition, because it sounds like your entry into this foray, so to speak, was a ton of self-study. Like, there was no board. You predated the board. You actually were part of the board, helped form it, all this kind of stuff.
Sure.
And so now at this stage in your career, you have this history, and we'll probably talk about, what's cholesterol and this, but it's like interesting how, like, in the modern day of evidence-based medicine, people forget there's sometimes a 20-year lag between data and clinical stuff.
Sure.
And you literally have lived that. That's been your experience.
And it's funny, when I was working at the lab, one of my jobs was, because they were calling up the lab all the time, stop offering this test, what the heck would you even, why are you assaying this? And I would be brought into those phone calls as somebody who had a high level knowledge of appropriate use of, but you'd be talking to a bunch of accountants, bean counters, somebody who they directed as medical director, who had a very limited knowledge on any of these things. And I would give them the scientific A, B, C's, and D's as to why each test is very appropriate in one ear there and out the other. Finally I got to the point where I said, it's a waste of time being on these phone calls. My credentials mean nothing. My experience mean nothing. They don't want to hear it.
What's interesting?
It's so tough.
Last
thing I'll say, one of the reasons I left medicine after 37 years, for most of my 37 years, I had nobody over my shoulder restricting me. They respected somebody's expertise. But then it got to the point where you had to have little algorithms for who can get this, who can, and that's it. If I have opportunities, people want to give me other employment. Goodbye, private practice. Yeah,
it's unfortunate. There's a whole generation of physicians like you, and actually, it was pretty standard 25 years ago that a physician would work till they're 75, maybe 80. Sometimes they'd work until they're actually like, you're kind of old. You come to work in a cane. You forget stuff. You need to retire.
Yeah.
And now we have people retiring, this happened with the pandemic where a lot of people in the local environment were like, I'm done. 55, a couple GI doctors retiring at 55. It's almost like you're removing 15 to 20 years of a physician's
No, I
career.
understand it. If I didn't get the lab opportunity, and after the lab, Peter, I'd have been in a rocking chair a long time ago,
Yeah, well,
enjoying retirement. I sort of love my retirement now, which is still teaching lipids because I love it. But you were looking for ways to get out of the private practice of medicine.
And heart disease, a lot of interesting statistics like quoting, heart disease is the most common cause of death in our country. If you're a female diagnosed with breast cancer, heart disease is still the most common cause of, so it's one of those things that's something as basic as cardiovascular disease, and obviously lipids are one of the, major risk factors. It's like a bigger deal. I think, in 1900, heart cardiovascular disease was uncommon. By the 50s, it was the most common cause of death in our country. And 74 years later, it still is, So let's make a little transition. One other thing you mentioned, everything you mentioned, where in that, because there's a bunch of different credentialing societies now, where in that does lifestyle, diet, exercise, where in your journey in lipid medicine do those, because in the functional medicine world, we always, the foundations are always like diet, exercise, kind of stuff.
And it has to be. But look, we're at the point in lipidology now where we believe anybody who does show up with a lipid disorder, there's an abnormal genetic process behind that. If you had a perfect genome, if that even exists, but at least say a perfect lipid genome, the genes that influence lipids, some of them minusculely, some of them disastrously, but we're created from billions of genes. So if you've got a few even minor genes by themselves, but they start pairing up in you, you will have what we call an abnormal lipid phenotype. That means the blood tests come back abnormal, whatever they're measuring or so. So like everything else, so if we all have genes that are sending us down to abnormal lipids, what it really influences a gene's what it's going to do to that phenotype. It's the environment that a gene gets exposed to. So in the lipid world, what are the environments of concern that lipid drugs are going to be influenced by? And clearly you start with lifestyle. And what does lifestyle include? Well, of course it's your nutrition, but it's your activity, your exercise, it's your sleep patterns. God forbid you're exposing yourself to toxins like the soldiers you talk about or the smokers that we encounter all the time. So it's genes plus environment and lifestyle. Now, part of the lifestyle is nutrition. So obviously, if you have a lipid disorder, somebody should be advising you on, if you're an expert in lipids, the type of nutrition you or the nutritionist that you influence or work with or respect might come up with a nutritional plan that would probably or likely be beneficial to a lipid disorder. The one thing you will find out, and I think you have to be open-minded on nutrition, there is no such thing as I'm going to memorize one diet, that's it for everybody, and I'm done. That is absurd. You know that. Yeah. So you do have to individualize a nutritional plan based on not only whatever lipids you get, other biomarkers, you get other historical things, physical examination, you're assessing their activity and their muscles, blah, blah, blah. And you're going to come up perhaps with solutions with all of them. You're certainly going to stop smoking. Despite no randomized blinded trial.
I think that's evidence-based medicine. There's no evidence. Like, what's your evidence? Like, common sense.
Same as for parachutes. No evidence, but most of them.
Did you read that? Did you read that BMJ article about that?
Right. Yeah, that's a great line. Yeah. So anyway, nutrition is part of it. But no matter what, even if you're an expert and you say, hey, you're insulin resistant, you're not. Here's the nutritional plan I'm coming up with. You've been eating too much saturated fat. You have to try your nutritional plan with addressing all the other things, sleep, muscles, blah, blah, blah. But if it doesn't work, you have to be prepared to abandon your nutritional plan and try something else. Even though what you suggest might work in the majority of people, you're going to find out diets can be funny, as far as solving a lipid disorder. I will then go on to whatever lifestyle changes you do come up with, and I've listed 4 or 5 that you'll approach to. If you still have a lipid disorder that puts the patient at cardiovascular risk, you must work on pharmacology into the world. And now that we're realizing the lipid or lipoprotein concentrations that are really necessary to say, with this, amount of certain biomarkers, it is impossible to get atherosclerotic cardiovascular disease. Our goals of therapy over the years, I told you when I started it was 300 total cholesterol. Now we're into LDL cholesterol or ApoB, LDLP if you're beyond lipid markers. Boy, every 5-10 years, the bar keeps getting lowered on what is an acceptable, what is an appropriate goal of therapy. Goals of therapy have always come in two directions. For the very high risk and for those who are not at high risk, basically, and of course you'd be more aggressive with the goal of therapy in the very high risk, but really those goals of therapy are merging. What's good for one is certainly probably good for the other. The one who's already had a heart attack, you're trying to prevent the next one, but in the other one's primary prevention, we're now calling it primordial prevention. Let's get your lipids, lipoproteins in balance so we can take the leading global cause of morbidity and mortality out of your picture. Concentrate on the other things. I have to worry cancers in you or arthritic things in you, bowel diseases in you, and you can zero in on that. But so the lipid management is nutrition and lifestyle and ultimately pharmacology. And the good thing in the year 2024, there is almost nobody outside of rare genetic lipidosis that you cannot get to a pretty good goal of therapy to eliminate atherosclerosis. But those people do require drug treatment. We basically have 4 drugs that you can use other than, we're not talking about pediatric homozygous FH where they have drugs that you're never going to use as an adult. 4 drugs, so there's not a lot to master even with the pharmacology nowadays.